Hello. Wow, beautiful.
Beautiful.
Thank you. So like Dr. Chris was saying, today is Mozambican Women's Day. And it's actually celebrated today because the 7th April marks the day which Josina Machel died. Yeah, thank you.
Tell them who Josina Machel was.
And Josina Machel was the spouse or the
First lady.
Yeah, no, she was not the first lady. She was
Spouse.
yeah, the spouse of Samora Machel, who came to be the first president of Mozambique. And Josina Machel was a young woman, and she was very strong and determined, and she really wanted to defend the Mozambican people's rights. So she actually fought in the independence war. She died on the 7th April, which is today, on 1971, and that is why we use this day to remind all the Mozambican women about our courage, about our strength, to remind us that we are daughters, we are sisters, we are cousins, we are mothers, we are warriors. And so that's why we celebrate this day.
And so the ladies have these pretty capulana prints on, and then tell them what you've done with your face.
Oh yeah, so we have the capulanas, which are this piece of fabric. They don't have the specific color, although me and Saldar are wearing blue today, but they don't have the specific color nor the specific pattern. They just need to be colorful and joyful. And they unite us from the north to south. It's one of the things that makes us Mozambican. And what else is it? Oh, and I am wearing, I don't know if you can see it. Is it here? Okay. I'm wearing this little white dots here. This is called musiru, which is made from a plant. And it's actually originally been used in the north to symbolize the pureness of women before they get married. And usually they use it in all of the face, but more modern people use it like just in some parts of it, or they make an actual drawing with it in the face, and that's it. So it's also part of our culture.
Awesome, thank you.
All right.
Wow.
Thank you for sharing. Good, you
That's-
look beautiful.
Thank you.
Oh.
So
All
Chris,
right.
where's you? You're not wearing a capulana tie today in honor of the women.
I was playing tennis. I just ran over here after a quick shower. So, but I'm here with them in solidarity.
We thank you so much for doing this, especially on Mozambican Women's Day.
Sure. You know, my computer has weak sound. So while the UCLA students are getting ready to present their case, we're going to try to log on another computer here that maybe has a better speaker so we can hear you a little bit better.
Well, before we do that, Chris, should we wait to show those photos until you're online better, or should we do that now because you can
Oh,
see?
that'd be great. Yeah, go ahead and do that now. You guys come over. I've got you on a big screen so everyone can see you well, Lee.
Okay, well, what we wanted to do just to kick off this session was to share with you a little bit of glimpse of the history of this partnership, which has been going on for 13, 14 years now, when we made the very first trip to Mozambique. And I have just a few photos to share with you. Excuse me, hold on. A few photos to share with you of some of the leadership from Mozambique and the faculty and residents that have come to LA, and we've tried to show them some of the sights of LA along the way. So it's our great hope that we'll get over this pandemic and that you folks will be able to join us someday soon as well. So a little bit about the UEM, Central Hospital of Maputo, and UCLA connection. And it started 14 years ago, and this was actually the very first trip that Dr. Risa Hoffman and I made. And this is the first day in country with Dr. Mamudo, who at the time was the dean who helped pave this pathway for us and has remained a good friend to us. And then a few years later, the dean of the medical school at UCLA, Gene Washington, joined us to come to Maputo for a formal signing ceremony to communicate the relationship between the two schools of medicine. And this was Dr. Washington meeting with the former director of the hospital as well at a signing ceremony. And then more recently, the Dean of Education here, Dr. Braddock, was in Mozambique with us with Dr. Sidat, and Dr. Sidat has become a great friend of ours as well. And it's been really wonderful to have him here in Los Angeles on a couple of occasions as well. So I hope this communicates to the students on both sides of the world that this has been a very strong bond for years. And now let's show the folks in Mozambique a little bit of LA through the eyes of our friends from Mozambique who have come to visit us here. And the medical students from Mozambique may or may not recognize some of these people, but these are a combination of pediatric residents, pediatric faculty members, and medical school leadership who have over and over again visited the Hollywood sign and the Beverly Hills, because there's a recurrent theme in these photos. They've also enjoyed a little bit of a run to Disneyland as well. You folks may recognize these pediatric players here as well. And then this is a very famous door in Beverly Hills. This is, I don't know, do the UCLA students know what this house is? I need to take the UCLA students before you graduate on my STAR driving tour. This is Michael Jackson's house, the house, his last home before he overdosed on propofol, and then he was taken to the emergency room at UCLA, and that's where he passed. But there are a lot of pictures of visitors from Mozambique in front of this house. And we couldn't have some images for you without a little bit of a view of the Pacific Ocean. And here we have the leadership in front of one of the entrances to, this used to be the old medical school building. Now there's a new building called Geffen Hall. And here's the famous, one of the famous Beverly Hills signs. And another zip to Hollywood. And we had a very large group of leaders come to the medical school to participate in a medical education workshop to look at different teaching methodologies and different tools for assessing learners. And this was great fun. It was a very sort of interactive 3-day workshop. Atanasio here has been to, he's the chief pediatric surgeon in Mozambique, and he's been to the States, I think, a few times now. All right, and for the medical students here, this is in block 9, and which is the neuroscience block, and this team was here at that time, and we wanted to give them a feel for how teaching is done in the neuroscience lab. So for the Mozambican students, this was a brain cutting session. And again, the Hollywood sign and the medical school. These were some of the leaders in the Department of Pediatrics. And there's the boss in front of the Hollywood sign. And others in front of the Hollywood sign. And others, these are all different visits. but it's the same sign. And this must have been a little bit of winter time because we've got some coats on. Dr. Sandra. Again, Michael Jackson's house. More visitors to Hollywood sign. These are the Hollywood Hills. It was not a clear day, but on a clear day, you could see the blue ocean out here. That would be the Pacific. And there's the first boss having a good meal in Los Angeles outdoors. And I realize you may not know all of these folks. These are some education leaders from around the country who came as well. Ah, and this one, does anyone recognize this person over there?
Grey's
Dr.
Anatomy.
Dr. Owen. Dr. Owen made a trip with us to Mozambique to learn about the partnership. And when we were flying from Johannesburg into Maputo, I was saying to him, his name is Kevin McKidd. I said, Kevin, you're finally going to be in a place where people don't know you and you're not getting stopped everywhere on the streets. And he smiled and said, that would be nice. And we checked into the hotel. And then I said, let's go to the hospital. And we went into the medical school building, and there was a scream, and all these medical students came running in the computer room and surrounded him and started screaming, Dr. Owen. And we then learned that at the time that Grey's Anatomy was the #1 show on television in Southern Africa. So so much for his anonymity, but he had a wonderful visit. And well, I'm showing you the hospitality that we try to extend to the Mozambicans when they're here. There is no greater hospitality than what Dr. Chris shows us whenever we're there. And it's always an exhausting time for Chris because he's running us around so much with every trip. But I'm sure that the Mozambican students are not surprised to know how beloved Chris is on this side of the world as well. And this was on a previous trip, and this is in front of the Southern Sun Hotel. So that's it for the slideshow, and I'm going to pass the baton now. I hope that was fun for folks on both sides of the world. Hold on. And now
that made me homesick, Lee. Thank you.
Sure. Did the Mozambican students recognize a lot of those folks?
Yeah, they're our teachers now. Most of them are our teachers, so.
Okay, that's fun. Well, you can tell them they appeared on the big screen today.
Yeah, totally.
All right, who's going first? And actually, Hijab, do you want to say something to just sort of set the stage for the level of interactionness and us being quiet?
So amazing.
Sure. So good morning and good afternoon to everybody. We really want all of you to just be able to present your case and talk about the social factors and on each side, what's kind of maybe contributing and what's similar or different in the different parts of the world that are kind of playing into that. But you know, we're here, but mainly we want to just let the discussion go and discuss with each other. But of course, we're here if there's, you know, any particular questions that arise or we can help in any way. But hopefully it'll be just a quick presentation for the case and then spending most of the time kind of talking through the issues.
So Chris, I don't know if you had your earphones in at the time, but Hijab was just saying that we're going to have a more passive role and hope that the students will ask lots of questions of one another, and at the end we could all actually get off the line and just give the students a chance to gab with each other if you want. All right, who's presenting on the UCLA side?
Hi everybody, my name is Vivian. I will be presenting. I apologize. I am zooming in from my car because we have 8 o'clock rotations, but actually Julia is going to share screen if that's possible. Share the slides. I do not have that capability on this phone. Thank you so much. Are you all able to see the slides? I can.
Yes.
Okay, excellent. So I chose a patient that I actually met yesterday at the Veterans Affairs building. And kind of just to give you a little bit of a background, if you serve in the United States military, Navy, or like armed forces, you for like a certain amount of time, you actually get medical insurance and care through that system. And this is really important because veterans have a lot of difficulty reassimilating into society because of things that they've seen. They tend to be homeless at a higher rate than the normal population. And they have a lot of other like specific needs that they have. So this is something the United States government provides for people who have served. So our patient is a 35-year-old male patient with actually no prior medical problems. He served in the Navy and is currently unstably housed, now presenting to clinic for complaints of, he describes being on edge. And when I say unstably housed, kind of just to give a background, he was homeless for about a year, living on the streets of Los Angeles, where we have a large homeless population here. And he's actually currently housed in a shelter that he was connected with through the Veterans Affairs. So for his current symptoms, he says that he feels like he's being watched constantly. And kind of, he's currently unemployed, so he takes a long walk every day for exercise and he walks to the beach. But whenever he sees the water, he actually thinks of dead bodies floating in the water. We asked him a little bit more about this experience, and it turns out he actually served as part of the relief service when there was that big earthquake in Haiti. The United States sent a lot of the Navy and other people over to provide food and help build shelter for the people of Haiti. And so during that time, he saw a lot of really scary things, including lots of dead people and people who had been really devastated by the earthquake. And so he actually always walks to the water every day, but he can't get in the water. It's a 4-mile walk, but he cannot get in the water or touch the water because of these thoughts. He has very poor sleep. He sleeps 3 to 4 hours a night. It sounds like he tries to sleep pretty early, but he isn't able to fall asleep for many hours, and then he wakes up very early. And he describes being on edge. And when he says this, he kind of describes that something is going to happen. He feels like something's going to happen to him, like someone's out to get him when he walks down the street, even though there doesn't appear to be anyone like immediately threatening to him. And when this happens, he has like rapid heartbeat and he becomes very sweaty. Next slide. Next. Oh, thank you. Okay, so for the social history, I mentioned he had been homeless. Since I think that actually should say December 2019, after his house burned down, and he's currently housed at a shelter. And he had a hard life on the streets. He reports getting robbed very often, and getting into fights while homeless. And he describes like over 7 instances. He's currently unemployed, looking for work. He has 2 children with 2 different women. One of his daughter is in Virginia, and then one is in Los Angeles. And he kind of has this like a little bit strained relationship with his ex-girlfriends, but he visits his children. He says that they're the reason why he wants to get better. And he doesn't use any alcohol or any other substances except for daily marijuana use. Next slide. And I kind of wanted to bring this up. So in the past like decade or so, there has been a lot of literature on adverse childhood experiences in the United States. Basically, these are things that you experience as a child, and they actually lead to poor health outcomes when you're older. These are things like being abused, being in like a single parent household, being exposed to substance use in the household. And he actually has lots of these adverse childhood experiences. And one major thing is that kids who go through these experiences as children, even if they are healthy later in their teens, they actually have poor health outcomes. So what that means is they have higher rates of diabetes, heart disease, and they have actually overall, I think, shorter lifespan. A few other traumatic events that he's experienced, other than the adverse childhood events that specifically fit into those categories, he did have a cousin who was murdered at around 20 due to gang violence. It sounds like he was involved in gangs in his teens, and he kind of joined the army because he was afraid that he was going to be next, that he was going to be killed. He also has some history of domestic violence complaints with his ex-wife. It sounds like they assaulted each other and the police had to get involved at certain periods. So I know that was a lot to think about. I chose this case specifically because it kind of shows like a young man who is like healthy on paper, but has a lot of risk factors for the future, and is kind of has a complicated social history. But does anyone have any questions?
Will you just sorry, will you just remind us what setting at the VA you met him? Was it in an urgent care clinic or like a chronic care clinic?
Yeah, so he actually decided to come in to a psychiatry appointment. He is getting primary care. We actually have this wonderful clinic called HPACT. It stands for, I don't remember what it stands for, but it's basically like the primary care hub for homeless clients. And through that clinic, we have a lot of different specialists. We have primary care physicians, psychiatrists, nurse practitioners, social workers who really try to support our homeless veterans in getting the care that they need, and kind of like setting them up for success for the future.
Thank you. So I'm going to ask you guys to try to come up with maybe what are some observations that you have about this patient's social history and his apparent, some of his mental health issues, or contrast compared to how a patient might, a similar patient might be dealt with here in Mozambique. But I'd be interested to get your reaction to this case. And feel free to talk about whatever comes to your mind.
I guess I also have a question. So homelessness is like a very big problem in specifically like Los Angeles and big cities. We get it's very expensive to live in Los Angeles. And so, but like a very desirable place to live. And so a lot of people will move here and then they won't be able to pay their rent. So they end up on the street. Does that happen in Mozambique?
Yeah, it's actually frequent, but it usually, I don't know, I think it happens more with children. They leave the houses because they have parents abusing them. And yeah, I think it's more like that.
There are also people who come looking for better job opportunities. For example, the other day I was out with a friend, and someone came to us saying that he had a hard time finding work. He came here because someone promised him a job, but when he got there, unfortunately, because of coronavirus, the person didn't want to accept didn't fulfill his promise to him. So he didn't have the means to go back home from where he came. He came from up north because he had no financial stability, and so he kind of became homeless from one day to another because he spent all of his money trying to come over to the capital here in Maputo to find a better job. And yeah, he came to us pleading for some help because he hadn't had lunch that day, and it was already almost 8 o'clock at night, and it was a really sad situation. So yeah, I think it also does happen over here. People looking for better conditions, and sometimes they aren't as lucky as others.
And another situation which I just remembered here is that a lot of adult people who are homeless, they have like mental illnesses. We have a lot of people with schizophrenia. Is that it? Yeah. And usually because we don't have this social understanding, people don't understand that it's a medical condition and that those people need some attention. So when the families realize they have a person in the family with a mental illness, usually they just leave them and abandon them. And actually these mental illnesses, people are very afraid of these mental illnesses here in Mozambique. And interestingly, we have a case which affects like the head, and it kind of goes into that as well.
Yeah, that's great to hear. I think it sounds like honestly this problem of homelessness, we share a lot more than I expected. Similarly, in the United States, we call them LGBTQ, so that is lesbian, gay, bisexual, transgender, and queer youth actually are homeless at a higher rate. Similarly, because their families don't accept them or they're abused. And so that's something that I think is kind of similar to you all. And also, like, similarly, a lot of people, they come to big cities to look for opportunities. Some people come to Los Angeles because they want to be actors or something else. But it's like one of those cities that's very popular. I guess I wanted to ask, what does the government do anything for these people who are in need in Mozambique? Oh, I think you're muted.
Well, unfortunately, no, but we have, I can call social community groups like churches,
But they're like
yeah,
or
it's like a private place who tries to help them, not the government and
private
person.
association.
Yeah, private
or-
association.
Even people with good intentions.
Yeah,
So
only
they have
that.
to.
Sometimes, for example, I have a friend who has, they call this solidarity group where they try to earn some money, and in the end of the month they buy rancho. Basic food, so they give them at the end of the month, so they try to leave, but it's not enough, but we try to do as much as possible. I think here in Mozambique, what is most people highlight the new it's because we help, like the community helps most than the government, those people.
Yeah, I think, oh, sorry, go.
I'm just curious. So we're working with this Veteran Affairs, which is like as Vivian explained, for the military. And a lot of times when people are homeless, they live in what we call encampments together, and there's kind of communities that form. Does that happen with people that are homeless in Maputo or throughout Mozambique?
Well, here in Mozambique, there are lots of abandoned like houses in which they get together as groups and they live there. For example, right next, no, on my street, there's a house. I don't know who the owner is, but there is a group of maybe 20 people who go there and they stay there overnight. And then during the day, they go out and do their affairs. We have some go looking for food, others are beggars in the streets. And they kind of take care of each other. So they're a community. But they also fight with one another a lot. So sometimes we have people who are seriously injured. Sometimes others actually die. And yeah, but I don't think there's like government establishments for them to go looking for. Usually they stay in these abandoned places. And it's really a problem for the government or for the owner of the land when they try to get rid of these people. Yeah, that's, I think, about it.
Yeah, it's a really similar thing here where it sounds like the government is helping these people, but I think this patient specifically has a lot of resources because he's a veteran. But most of the time on the street, people who are homeless don't have access. A lot of the aid in America is similar to in Mozambique, where people will donate and they will we have organizations who will provide food. There are some government-run shelters, but a lot of our homeless patients, they actually describe preferring to live on the street because these shelters are really crowded, they're dirty, and they're not very well kept. And so the government is doing some, but at least I don't think that they're doing enough. And you brought up kind of this like violence and fighting among the homeless. And so that, as we saw in this case, that happens to our homeless patients as well. However, I think something that was brought to my attention. Well, I've known about this for a while, but there are some recent events where homeless individuals in America are actually more likely to be assaulted than other people. And you might think that this is like homeless people infighting, but in America, actually, the homeless are the target of a lot of hate crimes, which people just think that they're lazy or maybe they shouldn't be there. They're on their land and they are creating a commotion or inconveniencing people. And so a lot of people will actually come and attack people and assault them, which is very scary. And a lot of our homeless patients have what we call post-traumatic stress disorder from these events on the street.
I wanted to actually ask a question. Well, one thing Vivian was saying how the patient in this case has extra services and things because he's a veteran. And so here, if you serve in the Army, I believe it's for a specific amount of time. And if you do certain types of work, you're eligible for like health benefits and services. And so thankfully, this guy can get plugged in to social services, but usually it's limited to just the veteran, and not all the benefits expand to their partner or spouse and their children. And I know here homeless youth is also an issue. I actually had a patient yesterday who was in his teens or young teens, and he was homeless. And I'm just curious to know what the foster system looks like for homeless youth, for kids, for you guys. Like, what is the process for children who maybe are homeless or they don't necessarily have family they can turn to, either because their parents can't take care of them or because they ran away?
Well, the state has some shelters for children that are abandoned. And in the other hand, there are private spaces with people with good intentions that they give them some shelter and support them. Even they pay some schools for them till they come to the university or finish the university. But most of the places depends on the donations from the other people. So it's just that.
Yeah, and I wanted to say something else.
But
Yeah, and I wanted to say something else. I was saying the churches here in Mozambique helps like a lot. I know so many communities now. I'm reminding because I used to go there, and they kind of a sort of a school what they build for them, and they teach them how to do things so they can live with those abilities they learn there. Like they can cook, they can make clothes, and they have, for example, last week they was teaching kids to draw, and they were drawing so beautiful things. And now they're saying, like, for example, if you want to have a draw, a painting that a child made, you have to give rice, and then the kid will give you the paint. So they are trying to improve. I think the church here helps like a lot. But some children are, I don't know, indisciplined. They are bad behaving children. They are just running away from home, and they do have a home. They just be in the street like during 4 or 5 hours asking for money. And you're seeing he's wearing a nice shoes, better than yours actually. And then he go back home, but he pretends that he's a homeless. They're just a bad behaving children.
God, thank you so much for explaining that.
You guys think we should transition and present the Mozambique case?
Yeah, I think this is a great time. Thank you so much for like teaching us a little bit about Mozambique and kind of the parallels that we have. But we'd love to hear your case now. Thank you so much.
And thank you, that was a great presentation. You maximize here, or you get the cousin? Yeah, and go share screen here, the green one. And there you go.
Share.
Share here.
It's my sister.
And you can do presentation view here.
Hello everyone. Once again, can you guys hear me?
Yeah.
Okay. So we are going to present a very sad clinical case about a young baby, adorable one, who unfortunately was diagnosed with hydrocephalus. Yeah. So I will be a bit quickly. Well, she is a JA 10 months baby, female, black, transferred from Inhambane Province Hospital that is here in south of Mozambique, where she was hospitalized for 1 week with diagnosis of meningoencephalitis, hydrocephalus with peritoneal ventricle bypass dysfunction, surgical suture descent, and severe malnutrition. So far, so good. Yeah. Well, I can see here. She came to us with a story of onset 2 days before admission to Inhambane, where she lives, with continuous fever, refusal to feed, focal seizures, sometimes with the high twitching, and others with tonic movements in the right arm, lasting about 5 minutes, associated with a purulent secretion through the side of the shunt on the head. There, in Inhambane, she was medicated with ceftriaxone, gentamicin, prednisolone, artesunate paracetamol, ibuprofen, diazepam in SOS, and therapeutic milk with no signs of improvement. So they decided to transfer her to Maputo Central Hospital, where we are, and she was observed by the neurosurgeon, who decided to remove the shunt as well as to drain the purulent secretion and restart antibiotic therapy and schedule the shunt reintroduction, for which she is awaiting. The time she was also observed by a nutritionist who started a nutritional therapeutic plan with F75. Can I proceed?
F75 is a therapeutic milk, guys.
Yeah, I thought they know. So her background history. The mother of the baby is 24 years old and started prenatal follow-up with. Sorry, can I just change very quickly?
Yeah, again with the technical issues.
Yeah, some technical issues. I'm so sorry. I will be fast.
No worries.
Stop share first. Stop share. Here, let me. I'm not learning right now, but.
Oh, yeah, sure. No, I don't. I just have 5 minutes. Ah, okay, it's this one.
Yeah.
Okay. Where is he?
This one, there you go.
Found it. The problem is, we also put dates for you guys to know from which time to which time she was transferred to the hospital and trying to get how much time she spent in the hospital.
Yeah.
So we already saw this one, and we already saw this one. You just have to know that she came to Mozambique and at January. Okay.
To Mozambique?
To Maputo. I'm sorry. Yes. So I was saying that she started prenatal cares at 23 weeks gestation, had 4 prenatal consultations in total. She tested for HIV and syphilis, and tests were negatives. And despite that, she had some complications. Urinary tract infections at 23rd weeks of pregnancy, and malaria and leukorrhea 29 weeks that were treated successfully as an outpatient. And the baby was born on May 20 by a vaginal delivery in the maternity ward at the local health center in term, and her weight was 2,700 grams. Her height was 50 centimeters. Her head circumference was 30 centimeters. Her Apgar score was 9 and 10 in the first and 5th minutes respectively. Well, her past medical history. Unfortunately, this baby has been living in this hospital since ever. And during her first month, the baby went frequently to the local health center due to a persistent crying. And the mother was always told that the baby had nothing wrong with her. And the mother decided to seek for better care, I can call that, at the provincial hospital in June of 2020. And still it was in Inhambane, where hydrocephalus was diagnosed, and the child was admitted and later transferred to Maputo Central Hospital on July 2020 for neurosurgical evaluation and treatment of refractory seizures. During her stay at Maputo Central Hospital, a ventricular peritoneal shunt was placed on December, and she was discharged after almost 5 months of hospitalization here at Maputo Central Hospital, with a plan to return every 3 months for follow-up with neurosurgery. So you guys can see she came here at January this year. So she couldn't even wait for those 3 months for coming to a follow-up, and she already had a complication of the surgery. And okay, her social history. The baby and the mother lives in Baran. It's a rural area in the district of Mashish, which is in Inhambane province. The nearest health center they have, it's about 20 minutes away from home by Shapa. Shapa is a minibus here in Maputo. It's a transport, and it costs 10 meticals. 10 meticals, how much dollar it is? It's like 20 cents. 20 cents. Okay. Irondina is the mother of the baby, live with her in-laws, her mother-in-law and 3 brothers-in-laws, and in a common ground with 3 separated precarious houses with 1 common bathroom and no electricity. Her husband lives and works in South Africa and as a mechanic and earning 3,000 rands, that is equivalent to $190. And he sends about $7 for her, for $70 for her month activities. So he visits her once a year during his summer holidays in December till January. And Irondina's mother also lives in South Africa with her siblings, and her siblings live here in Nimran. Well, she never met her father, the Irondina, the mother of the baby. Irondina studied until grade 10, and her husband only completed primary education. In Maputo, Irondina has an aunt who visits her at hospital once in a while, like once in a month, and she expresses disappointment about not being visited by her husband family members since this whole time she has been here in Maputo Central Hospital. Nobody comes to see her besides her auntie. And her relationship with her husband has been difficult ever since her mother-in-law expressed her concerns about the baby and how much investment was being made to a losing cause, according to her mother-in-law. But despite that, she is an amazing woman, like a strong one, and she believes her baby will have a healthy life, even though she understands the consequences of the disease, because she was well explained, and she knows that her child won't be a normal child, but she just wants her to be as much health as possible. So her physical exam. Okay, I will skip this one, but it's just for you to know that in the admission time she had severe malnutrition and her head was big. And I have here the photo of the baby. This is Jumena, her lady, and I also have another photos. Okay, this is Irondina, the mother, and this is the baby, and you can even see here she has and her head, she has pressure ulcers. Yeah, pressure ulcers during those lack of nursing support. She is cute. Okay, so after this, do you have any questions about Hironina, the mother, something maybe that I haven't said, but we can try to fulfill?
I have a question. Like, how far is the original hospital that they were at from Maputo?
About 600 kilometers.
It's about 600 kilometers. I know you guys use miles. I don't know.
It's not far. That's enough. And then is there like easy transportation?
Pardon?
She came with ambulance.
Is there easy transportation from
She came in an
area?
ambulance. She was transferred from the hospital.
I see. Okay. Yeah, is it common for like mother-in-laws to blame daughter-in-laws when there's something wrong with the baby?
Unfortunately, it is. They have so many beliefs here in Mozambique. They may say that they have so many beliefs, things that I don't even want to say. Like they blame the mother that she did something during the pregnancy, or she was with other men. They have a lot of
and there's like witchcraft belief is very strong here in Mozambique, like very, very strong. And it actually happens a lot. We have a lot of cases in which the mother-in-law is always saying that the daughter-in-law made something, or vice versa. And even when we were passing in the Medicina Legal, how do you say that? Medicina Legal.
Legal medicine.
Legal medicine, estágio. in our rotation in the legal medicine, we had a lot of cases of women that were beaten by family members because of this witchcraft belief, because they said that they were doing things to the children or to the family members, and it's unfortunately it's very, very, very common in here. And even Irondina is quite I would say lucky that they still let her stay in the house, and the husband still talks to her. He has been a little bit more distant, yes, but he still sends money to her. But in a lot of cases, what actually happens is that when they see that the child's not okay, they say, yeah, the problem is with the mother. You did this to the child, so yeah, just go away because this is just a burden to our family. And even the husband just lets the mother go, and all the family just leaves them be.
I have a question about accessing just levels of just accessing the medical care. I'm just curious to know, I think you had mentioned that the mother-in-law made a comment about how much this was costing. And I'm just curious, for children in Mozambique, are there any forms of like support or money, or is any of the hospital stay covered? I'm only asking because here, children who come from lower income families or who families can't pay, sometimes like they're eligible for certain types of insurance or things provided by the state for their medical needs to be covered.
We don't share the same luck, but everything is for free here in Mozambique for adults, child, elderly, everyone.
They have in the first admission to the hospital, if you come directly to the Maputo Central Hospital, you have a small price to pay. But if you start out from the peripheral hospitals, usually it's just for free. So because they want to make people start out from the peripheral hospitals to so that less patients come to the central hospital, in which, because we have limited doctors, limited resources, so they want to make people go.
Primary care first.
Yeah, primary care first. So that's why you have this little paying taxes in the Maputo Central Hospital. But if you start out from the peripheral levels, you don't pay anything. And if you get transferred from there to Maputo Central Hospital, you also pay nothing, zero. Even if you need surgery or whatever treatment you need, it's a governmental offer.
And when you are done with your treatments, you have the right to go back in an ambulance. You don't have to go with Shapa, with bus. You can go back in an ambulance.
Thank you so much for clarifying.
Yeah, thank you. That's like really different from our country, where I'm sure you've heard people can like have millions and millions of dollars in debt because of a hospital stay. I did want to ask, initially, when the mom was going to the health center saying that her daughter, or sorry, yeah, I don't know, child was not right, what type of practitioners are those? And like, what's their training? Are they nurses? Are they doctors? Are they specifically like pediatricians? Do they have like training in childcare?
They're technicians, right? Like they're
a physician's assistant.
Physician assistant. Okay. The type of the health provider, it's equivalent to a PA in USA. They are not doctors, but they can also give primary care to a child.
Oh yeah, we have in our health system, we have like these programs in which we are, because because everything is for free, we need to focus on our basic needs. So one of the points in which we act a lot is maternal and child care. We call it saúde materno-infantil, and we had a lot of nurses and PAs, right?
Yeah,
PAs specialized
that are trained to act in that area just to take care of the mother and the child.
Yeah, but they are not, they just know how to recognize some basic things like how to treat diarrhea and it's not diarrhea, it is. Yeah,
It is.
and cough and what else?
Yeah, because they have a book that they call ID, and where they just identify the child as severe patient, mild. Yeah, we follow a lot of protocols here. They follow protocols. They just have to identify, is it a severe patient? We have to transfer. If it's not, we can treat here.
Yeah.
And just try to relieve the symptoms and let them go back home. And they don't study a lot.
Yeah, basically they're trained to see if the child needs to be transferred or not, and if he doesn't, they treat it there, and if he does, they just transfer the patient to a better, so that the patient can have access to the doctors.
Guys, I'm seeing that we have 1 minute left, and so if I might interject, Kara, I remember you came here, and I'm guessing one of the more shocking things for you clinically was that room where all those kids with hydrocephalus live. And I tell visitors that I think it's a good barometer for how good a healthcare system is functioning, because there's so many things. There's preventive care for mothers with folic acid, and there's good postnatal care for babies who are born prematurely who might have had intraventricular hemorrhages, and there's good infant care, making sure fever is properly worked up and meningitis is diagnosed, and there's good primary care in terms of measuring head circumference and diagnosing things early. And then it's sad, even once you get diagnosed, you got to get referred from the district to the province to the central hospital in Maputo, and then you sit in line and the CT scanner is broken and the operating room isn't functioning. It's really frustrating. And so I think it's a great, clinically, it's a hard diagnosis for us, but I think the students did a great job showing how there's a lot of stigma and educational issues that also play into this. So I think we also learned a lot about homelessness in the US, and I'm guessing that you guys might want to interact some more in the future. I know I shared with Tracy and Vijeta all of your contact information, your emails and names, and maybe you guys could do the same from your end. And if there's interest, we would love for you guys to continue the discussion without us being involved necessarily. Lee, I don't know if you or Hijab want to say anything.
Yeah, I just want to echo that. I mean, this was great. I think both weeks we've just really hoped we had a little bit more time for everyone.
We're not hearing you very well, Hijab.
Better. Okay.
I was just gonna say, this has been really great. It's been very informative, I think, on both sides, and I just wish we had more time. So I echo those sentiments. I hope that this is just the start of all of you, staying connected and continuing to learn from each other, and hopefully, one day maybe some of us will be able to meet in person.
Yeah, and I'm just going to add a muito obrigado, and we've learned a lot. Thank you so much.
Thank you for the opportunity.
Thank you so much. We've learned a lot, and I really enjoyed our time together.
It was so nice to meet you guys.
Happy Women's Day.
Thank you. Não vais conseguir porque ali tens que fazer stop.
Tipo, tem que começar tudo de novo.
I don't know. Cancel the share.